basics of orthopedics, where we'll be discussing the structure and function of bone. I don't think whatever I am teaching you is going to be anything new for you. You would have already learned all of these things in your first year itself from your anatomy classes. This is going to be just a brushing up of all those things once again. That is all. Okay. And this chapter is going to be very important, and it lays the foundation of the subsequent chapters that I am going to take for you. Alright. So we'll start. Let's look at the structure of a long bone. So we are taking a long bone here because long bone fractures and injuries and tumors and all are what are usually asked for your exam. In a long bone, we know that there are three parts, isn't it? You have the diaphysis, metaphysis and the epiphysis. What is the diaphysis? This thing, isn't it? The long tubular part of the bone, the central part is called the diaphysis. And this expanded end on both sides are called your metaphysis. And the very ends of the bone, this much part of the bone is what we call as the epiphysis. Epiphysis. So basically every long bone will have a diaphysis, which is also called as the shaft of the bone. Then on either side of the diaphysis we have two metaphysis, and on the very ends of the bone we have two epiphysis. Okay. Now the same construct is there in pediatric bones as well. There is a very slight modification here. What is that? We all know what it is, isn't it? You have the physis or the growth plate there. Physis or the growth plate. The part above the physis is your epiphysis. Part below it is your metaphysis. And the central part again is your diaphysis. Now the important thing is, why is physis so important? We have heard about physis injury, isn't it? Physis injury is very severe. We are all scared of it. Why? What is so important about physis? Yes, very good. The physis is important in the linear growth of bone. Okay. The physis is responsible for the linear means lengthwise growth of bone. If there is an injury to the physis, what will happen? An injury to the physis will lead to growth arrest. What is growth arrest? There won't be any growth taking place there, which can lead to either deformities or even shortening of the limb. Remember, these are the injuries of a child. So it is very important that we take care of the child with a physeal injury very carefully, so that the child does not end up with any deformities or any shortening. Okay. Now let's look at the parts of a bone. We are cutting open the bone like this, and when we are looking inside, what do we see? We'll see that the long bone, the center is a hollow. What is it? It is the medullary cavity. The central part is hollow, and this is called the medullary cavity, and the medullary cavity used to be full of what? Would be full of bone marrow. Bone marrow. And if you see that the outer part of the bone is covered by a covering, and this outer covering is called what? It is the periosteum. Periosteum is the outer covering of bone. So when you look at the bone, you have the periosteum on the outside. When you cut open, you will see that on the inside you have the medullary canal, which is full of your bone marrow. And the interesting thing is that inside of the bone also has a lining, which is called the endosteum. You have an endosteal lining as well, which is not very important. Periosteum is very, very important for you. Again, a very interesting thing that you see is that the type of bone is little bit different in the epiphysis and metaphyseal area, and it is quite different in the diaphyseal area, isn't it? You also would have noticed, isn't it? You see that this epiphyseal-metaphyseal region, the bone is very soft, and this is called the spongy bone. Spongy bone, which is also called as the cancellous bone. Cancellous bone. Okay. What about the cortex? In the cortex, the bone is very, very thick. In the diaphyseal region, the bone is very, very tough and thick, and this is called the compact bone. Compact bone, which is also called as the cortical bone. So basically, you have two kinds of bone in the long bone. On the ends, you have the spongy bone or the cancellous bone, and in the center, in the diaphysial region, you have the compact bone or the cortical bone. What are the differences between the two? Cancellous bone is weak. Why? Because it is made up of meshwork of trabeculae like this. But cortical bone is hard because it is made of densely packed tissue. Now, what is the importance here? Because cancellous bone is weak, there is an increased risk of fractures. So please remember, this hash sign is equal to fractures. This is a universal symbol for all orthopedic surgeons. We cannot write fractures everywhere. So this hash symbol represents fractures. You would all know this, isn't it? During your internship, you would have all noticed this is your hash symbol is your fracture. So you have increased risk of fracture in cancellous bone and decreased risk of fracture in cortical bone because of this difference in strength. But there is an advantage for cancellous bone. Why? Because it is made up of loosely packed tissue. It has high vascularity because there is a lot of blood vessels that can enter into it. It has more surface area and has more bone cells. So even if there is a fracture, there is less chance of non-union. It will unite very well. I have never seen a metaphyseal fracture or a cancellous bone fracture going in for non-union. It almost never happens. But that is not the case with cortical bone. When you have a fracture in the diaphysis, which is made up of cortical bone, because of low vascularity, low surface area and less bone cells, there is a higher chance of non-union. So this is the difference between the properties between your cortical bone and cancellous bone. Okay. Now let's discuss something about periosteum, because you get a lot of MCQs from here. Periosteum, we all know what it is. It is the outermost covering of bone. We know that. And this periosteum, remember, it is attached to the surface of the bone with the help of tough fibers called Sharpie's fibers. This is a previous year question for you. Sharpie's fibers is the fibers that connect the periosteum to the surface of the cortex. Then remember, periosteum covers all bones except sesamoid bones. What are these sesamoid bones? These are bones formed inside what? Inside tendons. Yes, these are bones formed inside tendons, and the best example for a sesamoid bone is your patella. So remember, patella is a bone without a periosteal covering. This is again a previous year question for you. Patella is a bone without a periosteal covering. Now, periosteum also covers the entire bone except the articular surfaces. Why? Because you have the articular cartilage there. So that is devoid of periosteum. Now if you look at the periosteum is made up of two layers. You have an outer layer and an inner layer. The outer layer is called the fibrous layer and the inner layer is the cellular layer, which is also called as the cambium layer. Which is important layer? Cambium layer is the important layer. Why? Because it contains lots of osteoprogenitor cells. What are these? These are stem cells. These are stem cells which can differentiate to form osteoblasts. And what are the functions of osteoblast? What is osteoblast? Remember, B for bone building. B for bone building. Osteoblasts are bone forming cells. So whenever there is a problem with the bone, if it is a fracture or even otherwise, when the bone has to grow, the osteoprogenitor cells in the periosteum will differentiate into osteoblasts, and the osteoblast, being the bone building cell, will lay down new bone and form bone. So unless there is adequate amount of periosteum and osteoprogenitor cells, these things do not happen properly. Okay. Now with that basis, what could be the functions of periosteum? Obviously in oppositional growth. What is oppositional growth? It is increase in girth. Increase in girth. We talked about linear growth. Linear growth is contributed by your physis. Oppositional growth is increase in width or girth of the bone. This is contributed by your periosteum through the osteoprogenitor cells. Then in fracture healing, whenever there is a fracture, the periosteum gets stimulated and the osteoprogenitor cell in the periosteum will differentiate to form osteoblasts, and this will cause fracture union, and this will also help in some amount of bone blood supply to the bone. Okay, so this is the function of periosteum. Now let's look at the composition of bone. This is again a very interesting thing. If you look at the bone, you will see that it is very hard and tough and so. But the bone is actually made up of two primary things. You have organic part and an inorganic part. And the inorganic part forms 60%, of which 20% is just water. 20-25% is just water. 35% is made up of a mineral called calcium hydroxyapatite. That is an MCQ for you. Calcium hydroxyapatite. Now I told you there is also organic part, and this organic part of bone has a name, osteoid. Organic part of bone is called osteoid. That is an MCQ again for you. And osteoid has cells in it as well as protein matrix. And which are the three cells? Osteoblast, osteocyte and osteoclast. Osteoblast, as we discussed, is the bone building or the bone forming cell. Osteocyte is a resting cell, and osteoclast is the bone cutting. C is for bone cutting. C is for cutting, which basically means bone resorbing cell. Okay. Now if you look at the protein matrix, it is primarily made up of type 1 collagen. It also has some amount of osteocalcin and osteonectin. This is again another MCQ. Okay, the most abundant protein in bone. Which is the most abundant protein in bone? Most abundant protein in bone is type 1 collagen. So if you have any disease of type 1 collagen, can you tell me any disease affecting type 1 collagen? Scurvy. Scurvy is vitamin C deficiency, and vitamin C is needed for type 1 collagen synthesis. Then there could be a defect in type 1 collagen gene or called 1A gene, which will result in osteogenesis imperfecta. Okay, we'll learn about all those things later, and the basic concept you have to know here. Remember, the most important protein in bone is type 1 collagen. Okay, keep that in mind. Now let's discuss the various cells that we already learned in a little bit more detailed manner. I told you that there are 4 important cells so far, isn't it? One is osteoprogenitor cell, osteoblast, osteocyte and osteoclast. Of these 4, the 3 cells, osteoprogenitor cells, osteoblasts and osteocytes, are pretty much the same cell but in different stages of maturation. Actually, we know that osteoprogenitor cells are seen in the cambium layer of periosteum. These are the pluripotent stem cells. They, when stimulated, get differentiated into osteoblasts. And what is the function of osteoblasts? To lay down protein matrix of osteoid. It produces collagen, osteonectin, osteocalcin, everything. In fact, whatever things you see here is actually produced by osteoblast. The protein matrix entirely, collagen, osteocalcin, osteonectin, everything is produced by your osteoblast. It is actually the workhorse of the bone. In addition to all these things, it also produces a very interesting molecule, alkaline phosphatase. It produces alkaline phosphatase. Why is it interesting? Because we can use alkaline phosphatase as a proxy to analyze bone formation. Whenever there is increased bone formation, osteoblastic activity will increase, isn't it? So this means that alkaline phosphate production will also increase, isn't it? So this means that if you take the blood sample of the patient and you measure alkaline phosphatase and it is increased, what does that mean? It means that there is increased bone formation. So alkaline phosphatase is a marker for bone formation. Okay, we'll discuss about that later also. And finally, we have osteocyte. Osteocyte is the mature or the resting stage of osteoblast. The interesting thing is that there are 2 MCQs here. 90% of all cells in the bone is osteocyte. It is the most abundant cell here. It also has the longest lifespan. And the 4th cell is osteoclast. Osteoclast is separate from those 3. It does not come from that lineage. It comes from the reticuloendothelial system. Okay. It is formed by the fusion of monocyte progenitor cells. Because it is produced by the fusion of multiple cells, you get something like this. A cell with multiple nuclei, and one edge of the cell will have these finger-like projections, and this is what we call as ruffled borders. So it is multinucleated and has ruffled borders. With the help of the ruffled borders, it will attach onto the surface of the bone and it will release hydrolyzing enzymes and destroy bone. That is how it works. And when it does that, it will form a hollow or a cavity in the bone like this. Can you appreciate this cavity? And this cavity formed by the lysis of bone by the osteoclast is what we call as Howship's lacunae. And the osteoclast actually, this is the osteoclast, and it actually rests inside the Howship's lacunae. Howship's lacunae. Howship's lacunae is also an important MCQ. And like osteoblasts, which produces alkaline phosphatase, osteoclast produces another enzyme which is called tartrate resistant acid phosphatase, or TRAP. Tartrate resistant acid phosphatase. So if you can use alkaline phosphatase as a marker for bone formation, you can definitely use TRAP as a marker for bone resorption, isn't it? So it can be used as a marker for bone resorption. So in addition to these two molecules, there are a set of molecules that we can use as markers. So this is a table that is very important for your exam. So the markers of bone formation include alkaline phosphatase, osteocalcin, C-terminal propeptide of protocollagen type 1 and N-terminal propeptide of protocollagen type 1. And markers of bone destruction include TRAP, C-terminal telopeptide fragment of type 1 collagen and N-terminal telopeptide fragment of type 1 collagen. These are all previous year questions. Okay. This N-terminal telopeptide is also called as NTX, and urinary NTX can be used for diagnosing osteoporosis. Why is this important? In osteoporosis, most of the other biochemical evaluations such as calcium phosphate, level of parathyroid hormone, alkaline phosphatase, everything will be normal. Only thing different would be urinary NTX and TRAP. So this is an important MCQ. Urinary NTX or N-telopeptide can be used as a marker for osteoporosis. Okay. Now let's go on to osteon. We learned about osteoid. What is osteoid? That is the protein part of bone. What is osteon? It is the basic structural and functional unit of bone. Basic structural and functional unit of bone is osteon. And osteon is also called as the Haversian system. And the Haversian system is made up of few things. In the center of the Haversian system, this is your Haversian system or osteon. In the center, you have a central canal, which is also called as the Haversian canal. Around the Haversian canal, you have osteocytes. You have the Haversian canal like this. Around it, you have osteocytes arranged in layers like this. This is called concentric lamellae. Osteocytes arranged in layers around the Haversian canal is concentric lamellae, and after around 15 to 20 Haversian canal concentric lamellae, you get an outer boundary like this, which is called the cement line. Now, important MCQ you must remember is this: the central canal of adjacent osteons can be connected together like this with the help of a horizontal canal called Workman's canal. So this is an MCQ. Remember, Workman's canal is seen in the bone and it connects to adjacent Haversian canals. Okay, so this is the basic structure of an osteon. Now let's quickly look into bone remodeling. What is bone remodeling? Do our bones remodel? Yes, our bones do remodel, and it is a continuous process taking place every second of our life. Okay, so this is a continuous dynamic process by which bone is reshaped in response to external stresses. So that is your bone remodeling. There are two laws you need to remember here. One is your Wolff's law. Wolff's law is a very plain statement. It just says that bone remodels in response to mechanical stresses. That is all. Then we have something called Hütter-Workman's law. What is that? It is something that relates to physis in a child. Physis, we know, is the growth plate. What happens if you compress the physis? Tell me. What happens if you compress the physis? It is going to inhibit growth. What happens if you stretch the physis? Not too much. Gently stretch the physis. What will happen? It will increase the growth, isn't it? So compression across physis will cause inhibition of growth, while traction will cause increased growth. This concept is called, or this law is called Hütter-Workman's law. Two MCQs for you. Alright, now let's quickly look into the layers of articular cartilage. Articular cartilage, we know, is seen in all of these synovial joints, and articular cartilage has several layers. You have the superficial zone, the middle zone, deep zone and the calcified zone. Important MCQ here is this tide mark. Tide mark is a line which separates the deep zone from the calcific zone. So this is an important MCQ, tide mark. Two questions can be asked. First question is, where can you see tide mark? Tide mark is exclusively seen in articular cartilage, nowhere else. Next question they can ask is, between which two layers is tide mark seen? It is seen between C and D, calcific zone and deep zone. It is seen between C and D, calcific zone and deep zone. Remember this, okay? Now before we go on, let's quickly I'll repeat that. Now let's quickly see the basics of radiology in orthopedics. Again, this will be helpful when we learn the subsequent chapters. See, whenever we are taking x-rays for any injury or for any diagnosis, we have to take two planes perpendicular to each other. Generally, we take an anteroposterior or an AP view and a lateral view. This is the general principle. Rarely, we can also take oblique views, especially in the hand and the foot. And what happens if you don't take two views? This will happen. If you take one view only, you can see that our Prince Charles is showing the middle finger to someone. But is that what the reality is? No, you have to take the AP view. In the AP view, you can see that he is completely showing something else. Okay. So this is why it is very important to take two views before commenting on any X-ray. Very, very important point. Okay. So whenever we are taking an X-ray, so I have just given an X-ray of a child for representative purposes, just to show you what are the parts of a bone that you can see in an X-ray. This is also important for you. So just see, you can see this fine line here. This is an X-ray of a child. What are these fine lines? These are your physis or the growth plate. And this part is your epiphysis. This is the metaphysis and this is the diaphysis. You can see the markings here. This is the growth plate, this is the epiphysis, the metaphysis and the diaphysis. Okay. So we have finished our first chapter. Let's quickly discuss some important MCQs. Cells involved in bone remodeling are osteoclasts, osteoblasts, both A and B, or osteocytes. What is the answer? Don't say osteoclasts or osteoblasts. It is both A and B. In order for bone remodeling to take place, you need bone to be taken away from some part and deposited in some other areas. Okay, it cannot be a one-way process. The bone cannot be continuously destroyed. It cannot be continuously made. You have to take from one hand, you have to give from one hand. So there's a combination of osteoclasts and osteoblasts which are responsible for bone remodeling. Okay. The osteoid contains all except osteocyte, Haversian canal, protein matrix, or calcium hydroxyapatite. What is osteoid? Osteoid is the organic part, isn't it? It is the organic part of bone. And in organic part, we have osteocyte. Cells are there, Haversian canal, protein matrix, everything is there. Calcium hydroxyapatite is a mineral. So that is not a part of your osteoid. So the answer is calcium hydroxyapatite. Let's look at the third question. Which of the following is a marker for bone destruction? Alkaline phosphatase, N-telopeptide, osteocalcin, osteonectin. What is the answer here? Alkaline phosphatase, osteocalcin and osteonectin, these are all markers for bone formation. Okay. N-telopeptide is the answer here. It is the marker for bone destruction. Final question. Tide mark is seen where? Bone, hyaline cartilage, articular cartilage, cornea. What is the answer? Yes, tide mark is seen in articular cartilage. That is the answer.